Although intranasal endoscopic Dacryocystorhinostomy is gaining clinical acceptance and popularity, the external DCR is regarded as the gold standard in the term of surgical success with a high patient satisfaction. In today's current concept IC, myself, Dr. Ravi Ranjan, chairman of this session, I shall speak on introduction and DCR simplified and dealing complication and challenges. I am alumni of RIMS Ranchi. Dr. Amit Raj, currently working as additional professor and head department of ophthalmology, AIIMS Patna. He is ex-faculty for GMC Chandigarh, area of interest, cornea keratoplasty, pediatric cataract, published more than 50 articles in peer-reviewed national and international journals, and member of editorial board and reviewer of various journals. And he is recipient of Dukharam Gold Medal by Bihar Ophthalmical Society in 2008 and Best E-Paper Award in Confluence 2013 at Hyderabad. My next speaker is Dr. Gyan Bhaskar. He is a professor and head Unit 2 Orbit and Oculoplasty Services at RIO Indira Gandhi Institute of Medical Sciences, Patna. He is currently Secretary of Patna Ophthalmical Society. He is member Scientific Committee, Bihar Ophthalmical Society. Various publications in PubMed and Index Journal and presentation in national and state conferences. He is a PG examiner and in various universities, awarded for Gold Medal by BOS, Dr. D.K. Bose Gold Medal, Dr. Ajit Sinha Gold Medal, and Dr. A.K. Prasad Gold, virtually all gold medals by Bihar Ophthalmical Society. My next speaker is Dr. Sudhir Kumar. He will deal with step-by-step external DCR. He is an alumni of AIIMS New Delhi, DNB, MNMS, and currently working as a professor and head at a government medical college, Bettiah, since 2002. And he worked as a RIO IGIMS. He worked for several projects in association with Rajendra Institute of Medical and Research, ICMR Patna. And he is practicing ophthalmology since 2002. He is managing editor of Bihar Journal of Ophthalmology, treasurer Bihar Ophthalmical Society, past secretary of Bihar Ophthalmical Society, and overall he is great guide, philosopher and friend of mine. And he received all the gold medals for best free paper, best poster, best essay from Bihar Ophthalmical Society. He is that much learned man. And our next speaker is Dr. Ajay Kumar Sinha. He is going to talk on laser and endoscopy DCR. He is again RIMS alumni. He is ex-treasurer of Patna Bihar Ophthalmical Society, now president-elect of Patna Ophthalmical Society, and he is currently working as an assistant professor, Patna Medical College, Patna. Thank you. May I call Dr. Amit Raj? He is talking on be familiar with lacrimal drainage system. Amit.
Thank you, sir, for kind introduction. So, coming to my topic, like any surgery, before performing surgery, knowledge of anatomy and anatomical landmark is very important to minimize side effect or complication. So, there is whenever a patient comes with watering, either there may be hyperlacrimation or EP4I. If this balance is deranged, so patient will complain of watering. So, whenever we talk about lacrimal system, it consists of main lacrimal gland, accessory lacrimal gland, and drainage system mainly consists of upper and lower puncta, paired lacrimal canaliculi, lacrimal sac, and nasolacrimal tract. Coming to the main lacrimal gland, it is located in upper lateral aspect of the globe, and it has two parts, orbital and palpebral part. Orbital part is larger and palpebral part is smaller, but important thing is there are 10 to 12 main gland, main duct that pass through the palpebral part. If it is damaged, then lacrimal secretion is deranged. Coming to the accessory lacrimal gland, these are mainly two, gland of Creutzfeldt and gland of Wolfring. Gland of Creutzfeldt is located in fornix and more in upper compared to the lower fornix. Gland of Wolfring is located in just above the upper tarsus or 2-3 along the lower border of tarsus. Basal secretion is of the tear is by accessory lacrimal gland and reflex secretion of tear by main lacrimal gland. Coming to the puncta, these are opening of 0.3 millimeter in diameter located in the medial aspect of upper and lower. Basically, puncta is the junction of pars ciliaris and pars lacrimalis. Pars ciliaris is a ciliated part, lacrimalis is a non-ciliated part. And inferior puncta is approximately 0.5 millimeter lateral to the upper puncta. Puncta are relatively avascular, so while dilating, one can dilate it 2-3 times. And another important, due to elastic tissue, it has pale appearance. So localization is very easy. Coming to the canaliculi, there is upper canaliculi and lower canaliculi. And in one canaliculi, there is vertical part and horizontal part. Junction between the vertical and horizontal part is called ampulla. Vertical part is 2 millimeter and horizontal part is 8 millimeter. Generally, it opens into sac as a common canaliculi, but in 5 to 10% cases, maybe 5% cases, it can open separately. Canaliculi are lined by non-keratinized stratified squamous epithelium that is surrounded by elastic tissue. Another important thing is while punctal dilatation, one should respect its direction. So one should first start vertical, and then one should pull the eyelid laterally, and then it straightens up. Similarly, in case of probing also, one should go from the upper canaliculi. Again, while engaging it, one should go for lateral pull. Another important landmark is valve of Rosenmuller. It is the basically junction between the common canaliculi and sac. So this is basically it prevents the retrograde flow of tears from sac to the canaliculi. But it is an incomplete valve because while blowing the nose, air can go through the puncta. Lacrimal sac, another important landmark. It is bounded anteriorly by the frontal process of maxillary bone, that is called anterior lacrimal crest, and posteriorly by the thin lacrimal bone, that is called posterior lacrimal crest. The fossa is approximately 16 millimeter high and 4 to 9 millimeter wide, and it is around 2 millimeter deep. Those who are performing nasal DCR, endoscopic nasal DCR, lacrimal bone can be localized intranasally by just anterior to the uncinate process of the ethmoid bone. So what is the important surgical tip? One should avoid injuring the angular vein during a skin incision. It is around 7 to 8 millimeter from the medial canthus. So safest incision is over anterior lacrimal crest. Second surgical tip, how one should localize the anterior lacrimal crest. One should feel the inferior orbital margin, and then one should go up, and incision should be around 10 to 12 millimeter. Another important surgical tip is one should restrict bone window to area between anterior and posterior lacrimal crest, that is lacrimal fossa. As going beyond that, one can open into the paranasal sinuses. These are the relations of lacrimal sac. Important one is the fibers of LPS goes at the level of sac, so that is why it maintains the lacrimal pump. So, what are the parts of lacrimal sac? There are two parts, fundus as well as body. Fundus, that is, it extends beyond the medial canthal tendon, and body is around 10 millimeter below the fundus till the osseous opening of the nasolacrimal canal. Another important thing is the periosteum then continue inferior to enclose the nasolacrimal duct, and lacrimal fossa is surrounded by the fibers of the orbicularis oculi muscle. So, superficial head of the orbicularis muscle travels around the front of the sac to attach the anterior lacrimal crest, and deep head of the muscle travels behind the sac to attach the posterior lacrimal crest. So, important one is while separating the orbicularis oris, one should go for blunt dissection, and it should never be cut, otherwise there is chances of bleeding, and important thing is there is loss of lacrimal pump function. Coming to the nasolacrimal duct, it is directed posterolaterally, and it has two parts, 12 millimeter superior part that is intraosseous within the maxillary bone, and 5 millimeter inferior membranous portion that runs into the mucosa just below the inferior terminate. There are different sinuses or valve. Most important one is the Rosenmuller valve and Hasnell valve at the level of inferior meatus. Valve of Hasner is very important as it at the time of birth 70% of cases it is imperforate. So, a spontaneous opening occurs at around the age of 6 to 12 months. So, one should wait for conservative measures. Coming to the vascular supply, arterial supply of the sac area is by just 1 minute, sir. Lacrimal artery, that is branch of ophthalmic artery, venous drainage by ophthalmic vein, and sensory supply by the lacrimal nerve or branch of the ophthalmic, that is branch of ophthalmic vein, ophthalmic division of fifth nerve, sympathetic nerve supply by carotid plexus. So, to take home message is with proper understanding of anatomy of lacrimal drainage system and anatomical landmarks, success rate of lacrimal surgery can be maximized. For skin incision, trace the anterior lacrimal crest by palpating upward from inferior orbital margin. Injury to the angular vein can be avoided by making a skin incision on anterior lacrimal crest. Orbicularis oculi is essential for lacrimal pump function, therefore, fiber must be separated by blunt dissection. One should never cut it. In infants with watering, imperforate valve of Hasner may be the cause of chances of a spontaneous recanalization. After conservative management, it is high. Thank you very much for patiently.
Thank you, Amit. We shall start question and answer session after the presentation, I think.
Thank you.
It will be more easy. And our next presenter is Dr. Gyan Bhaskar. He is speaking on physiological tearing and case selection in DCR. Time allotted is 7 minutes, 7 to 8 minutes.
Good afternoon, everyone. Thank you so much, sir, for giving the opportunity, and may I thank the scientific committee of AIOS for this opportunity also. Chalo DCR, Pathshala. In this session, I am going to discuss about the physiological tearing and case selection. After the proper knowing the anatomy of the lacrimal passage, physiological tearing and case selection is a very important part. As we know, the tear secreted by the lacrimal gland passes through laterally across the ocular surface to the lower canaliculi, and then they finally pass through the lacrimal sac to the nasolacrimal duct. Tearing can occur due to the excessive secretion or blockage in the internal lacrimal passage. Tearing may be either it is due to the psychosocial stress or due to the reflex lacrimation. Where we are dealing with, we are going to discuss about the obstruction in the nasal passage. Some of the cases are presented with like this young child presented with the matting of the eyelashes, some discharge, swelling of the sac area, cystic lesion. And it is very important to diagnose these cases. And the other presentation would be in the younger child, like fistula, swelling, and discharge. Some of the patients are also presented with the preseptal cellulitis, swelling, and some of the patients present with the pain and swelling of the lid at the sac area and involvement of the upper and lower area of the lid. Some of the patients also presented with in the younger age group, like tearing, swelling, and some of the patients are also present with the mucus and mucopus discharge. And also some patients came to us with the post-operative blockage of the nasolacrimal passage. And in the older age group, some patients may present with the mimicking with the cystic swelling. It may be the other lesion other than the sac lesion. So it is very important to diagnose. The main aim of diagnosis is to first to confirm the diagnosis, then to evaluate the status of the sac, and to exclude any nasal pathology, so that we make to plan the surgical procedure to minimize the complication and increase the success rate of DCR. For the evaluation, we have to take the proper careful history. Here, history is very important for the diagnosis of any kind of disease. Like in the cases of Dacryocystorhinostomy, the patient is presented with the watering, the proper history should be taken regarding the one side of the disease or any trauma or any pathological lesion or any systemic osteosis should be taken care, should be properly, history should be taken. In the clinical examination, inspection is very important regarding any discharge, matting of the eyelashes, or any swelling of the around the sac area. Swelling may be in the above and below the medial pulpal ligament. The nature of the swelling and nature and condition of the skin should also be look. Then the proper slit lamp examination is mandatory to rule out any other causes of watering, like entropion, dystichiasis, trichiasis, or any ocular surface disorder, anterior chamber should be examined. After the slit lamp examination, just we have a OPD procedure like regurgitation test, syringing test, and some dyes should be used to rule out the pathology, to rule out the obstruction in the nasal passage. And one important thing is to examination of the nasal examination. If you have the endoscope or with the help of our ENT colleague, nasal examinations should be mandatory. And if required, we can go for the imaging technique like in the failed DCT or DCR cases. Just you see here in the regurgitation test, you can just push over the sac area and you see there is the regurgitation is positive or not. If there is a regurgitation is mucus or mucopus regurgitated, it indicates that there is a blockage in the nasal passage. If there is no regurgitation, it indicates that there is a common economic blockage. Sometimes there is negative regurgitation can occur if the patient came to with already expressed their sac manually. If it is not confirmed by the regurgitation test, then we go for the syringing procedure. By the help of syringing, we can rule out where is the blockage, either it is nasolacrimal blockage or it is blockage in the common canaliculi or canaliculi area. Probing test can be done to rule out soft stop or hard stop. In cases of there is a soft stop, then it indicates that there is a blockage in the nasolacrimal duct. Then in the younger child, if patient is uncooperative, then we can go for the fluorescein dye disappear test. Just instill a 2% fluorescein dye to the cul-de-sac area, wait for 2 minutes and just observe. You see here there is a fluorescein dye was instilled in the patient eye. One in the right eye dye disappear, but there is a left eye, the dye is present. It indicates that there is a blockage in the nasal passage. We can also go for the Jones dye test. It indicates that there is the primary test differentiate from the watering for the partial obstruction or the primary hypersecretion. And Jones dye 2 test also we can syringe with the normal saline and observe for the cotton swab put on the nasal cavity. If there is a cotton swab is stained with the dye, it indicates there is a there is a pattern. That means there is a partial blockage or physiological failure, pumping failure. If there is a fluorescein dye is not observed, then it indicates that there is a blockage, complete blockage of nasal passage. Then we can go for the X-ray or imaging technique like dacryocystography or radionucleotide dacryocystography to rule out the remain sac in cases of DCT or failed DCR, so that we can make a plan for the further treatment. CT scan or MRI can be done in cases of this type of the suspected cases to rule out the mass lesion and underlying bony condition. Before, in the cases of congenital diagnosis of congenital cases, one should look for the if the patient is having the photophobic, then there must be the cause of other lesion other than the dacryocystitis. And if it is not possible, then we can go for the examination under anesthesia. Before going to the any management, systemic evaluation is mandatory. Pre-operative checklist should be care of the control of the blood pressure, ENT evaluation, if patient is on blood thinner should be stopped, or pre-operative medication, ethamsalate or nasal decongestion can be used. And patient always should keep your anesthetic in OT if required general anesthesia. So ideal case would be the regurgitation test is positive, and if you want to go first DCR, then we choose a patient of the mucocele or the bigger, we can get a bigger flap. So flap make is very easy. So conclude that careful history is mandatory, and careful examination is also should be done, and it should be differentiate between the common clavicular and nasolacrimal duct obstruction, and treatment plan should be done according to the condition of the and blockage, vary the blockage. Thank you so much, sir.
Thank you, Dr. Gyan. Our next speaker is Dr. Sudhir Kumar, and he is talking on a step-by-step external DCR.
Good afternoon. External DCR is one of the most important surgery for nasolacrimal duct block, and we all know that in chronic dacryocystitis cases there is a block at the junction of sac and nasolacrimal duct, and this external DCR is still one of the most successful way of treating such cases. In this anatomically we want to create a bypass of blocked NLD by making a fistula between lacrimal sac and nasal cavity, and functional goal is achieved by relieving of symptoms of epiphora, discharge, and recurrent inflammation, which we call acute and chronic dacryocystitis because of recurrent pericystitic, that is inflammation around the sac. And we all know about the anatomy, and sac rests in the lacrimal fossa, and this is the anterior crest. And we have to make a passage in the bone here, which is anteriorly, which is formed by maxillary bone and then lacrimal bone. And sorry. Cursor नहीं काम करता है क्या? This is the place where इसको full screen करके दिखाएं, उसमें आना चाहिए. DCR is one of the most safe surgery because there is no fear of endophthalmitis. and this is one of the early surgery which one should do during the PG time. This is the place where we tend to make a passage between the sac and the nasal cavity. And we will be de-roofing this place from lacrimal bone and this frontal process of maxillary bone. And this is indicated in all the cases of primary and secondary NLDO and congenital nasolacrimal duct obstruction, which is not responding to other conventional treatments. But it is contraindicated in malignancy, atrophic rhinitis, dry eye, bleeding disorders, tuberculosis, rhinosporidiosis, and relatively in older age group where the tear film is less. And you should have a DCR set which has a bone punch, lacrimal probe, and punctum dilator, etc., which is a nasal pack, speculum, etc., and lot of gauze pieces and cotton and xylometazoline nasal drops. And patient should be on good control of blood pressure, and they should not be on any blood thinner. Nasal packing is done before the surgery with the ribbon of gauze piece pack, which is soaked in lignocaine and xylometazoline. We are not using nowadays adrenaline because that may cause hypertension in older age patients. And before we go into the direct surgery, we know that most of the surgery fail because of healing of that bony ostium and inappropriate location of the of the bony opening, that which may lead to some syndrome in which anatomically there is passage, functionally it is not working. So it's very easy. Incision is made at the anterior crest here, lacrimal crest, because it's easy to diagnose anatomically with the fingertip only. And another way of making incision is at around 8 to 10 millimeter from this medial cantha, but always 7 to 8 millimeter is avoided because there is angular artery and vein. And usually in adult cases we use local anesthesia, which is basically lignocaine with adrenaline and bupivacaine. And I actually tend to infiltrate all the area of sac here, and we put injection at the junction of the inner and upper junction of the orbit, and from there I infiltrate those that xylocaine and lignocaine and bupivacaine injection with here in this sac area, superiorly, inferiorly, and behind, everywhere, so that it gets diffused. And there is anesthesia in the whole region. This will take care of all the nerves. And incision is at the most preferred incision for me is at the anterior lacrimal crest, J-shaped incision, right from the just above the medial palpebral canthal. You can feel it here with fingertip, and from there 8 to 10 millimeter below in J-shaped. And this incision is only skin deep. And if it starts bleeding, you can use cat's paws that is going to give pressure over the skin margin, that will certainly reduce the hemorrhage. And then this medial palpebral ligament is exposed, and from here to here, then lacrimal, this orbicularis is dissected bluntly from throughout the incision, and then MPL is disinserted from the origin by 11 number of blade, and this disinsertion of MPL itself opens up the periosteum, and blunt dissection is carried out, and then periosteum is elevated throughout the area of the sac by periosteum elevator, anteriorly, posteriorly, inferiorly, and superiorly. And posterior crus of the MPL is not disturbed, because that may change the contour afterward of that lid, and that will then, even if the anatomical goal is achieved, there will be epiphora. So this area here, the bone will be deroofed, that is from here you will start making a ostium with bone punch. This is lacrimal bone, and keep going here and deroof this and lower part of the nasolacrimal duct also. And so the anterior, it is till punch cannot be inserted between the bone and the nasal mucosa, and posteriorly till removal of the aerated ethmoid, and superiorly till 2 millimeter above the medial canthus. Inferiorly till the nasolacrimal canal is partly deroofed. And then this making flap in the sac is very easy, and you can put lacrimal probe and tent the sac, and with the help of tenting we can make either U-shaped or 2 vertical slit and then horizontal slit, and then this is cut, and this makes the sac in this makes upper flap as well as lower flap. You can cut the lower flap, and this in the same manner nasal mucosa is also cut, and both the lower flap may be cut and upper flap can be sutured by 2 or 3 sutures, and this may be further attached with the periosteum so that this does not sag. And after that, the orbicularis is sutured with 6-0 Vicryl, which is followed by a skin with 6-0 silk. And bleeding is many a time a problem. For this, good nasal packing and assurance, and make the less use of, or rather judicious use of adrenergic drugs should be there. And while during this surgery, the wound may be a good pressure can also most of the time controls the bleeding from the wound, and you can also suck the wound from there. With this, I say thank you.
Oh, thank you, sir. Thank you, sir. Our next speaker is Dr. Ajay Kumar Sinha. He is speaking on laser and endoscopic DCR. Time allotted is 6 to 7 minutes. Sir, you have already loaded your...
Yeah, I have loaded it.
Yeah, so why not you are...
I was trying with my own presentation actually. Good afternoon, friends, and thank you, Dr. Ravi Ranjan, for believing in me and giving me this opportunity. Dear friends, as we all know, that surgical intervention by DCR is the mainstay treatment for epiphora, resulting from nasolacrimal duct obstruction. And the goal of our DCR surgery is to re-establish canaliculi outflow by creating a bypass into the nasal cavity. Initially, or why say initially, even nowadays, DCR is performed as an external procedure. And it still is a gold standard. But ये दिल मांगे मोर, वाटरिंग तो बंद हो ही जाए, वो स्कार भी ना रहे तो और अच्छा. So over the past few decades, several advances in technology have enabled us to perform this procedure with better cosmesis. At the very outset, let me declare that I have no financial interest in this presentation. And also, my acknowledgement to Dr. Satanshu Mathur, Director, High Tech Institute and Laser Center, Kashipur, Uttarakhand. I have borrowed his slides. More recently, minimally invasive techniques like transcanalicular laser-assisted endoscopic DCR have gained popularity. Now, what is this TCLD? Under endoscopic guidance, osteotomy is made with the help of diode laser. That's all. Advantages. Let us talk about the advantages of TCLD. Now, currently, TCLD procedure is performed with an incision-free technique. Actually, we don't need any incision for this. And this avoids visible scarring, requires short surgical time, produces less bleeding, and it's also easier to learn than the other DCR methods. I have enumerated the advantages: bloodless surgery, quick recovery time, OPD procedure. Yeah, we use topical anesthesia. Medial canthus is preserved in the surgery. Repeatable. If one fails, we can repeat the surgery. Another advantage, we can use it in a failed DCR or DCT cases also. And what are the equipments? Special equipments which we need? Just an endoscope and a fiber optic probe. Optical fiber. The fiber optic probe which we use is 600 micrometer. It's semi-rigid. And to avoid complications like secondary burn in canaliculi, puncta or eyelid, in the eyelid, we use a metal guide wire. The laser, let's talk about the laser which we use nowadays. 980 nanometer wavelength, commonly used diode laser. We use diode lasers nowadays more commonly. This diode laser works in contact mode only. It creates evaporation and coagulation at the site of contact only. Case selection is again very important. It should be avoided in patients with deviated nasal septum, medial turbinate hypertrophy, canaliculi blockage, and acute dacryocystitis. Anesthesia. What is the anesthesia which we use? Topical. Mixture of lignocaine with adrenaline is used for nasal packing, at least 15 minutes before the surgery for 5 minutes. And local by infiltrating a mixture of xylocaine with adrenaline in the nasociliary area to block the infraorbital and infratrochlear nerves. I'll show a video. Again, this
topical and local anesthesia. Under topical anesthesia, nose is packed with mixture of lignocaine with adrenaline for 15 minutes before surgery. Local anesthesia is given by infiltrating mixture of xylocaine with adrenaline in nasociliary area, blocking infraorbital and infratrochlear nerve with the injection of 1 ml of anesthesia.
Next. What exactly do we do in this laser DCR? What do we do? Under nasal endoscopic guidance, laser fiber optic probe is introduced through the upper or lower punctum, passed through the canaliculi, up to the medial wall of the lacrimal sac, and an osteotomy is made in the lacrimal bone, of course, using laser power, and this thus bypassing the nasolacrimal duct obstruction.
Sir, be fast.
This we have already said. This can be avoided.
Because we are running short of time.
Two things I would like to highlight. Intubation is important. Intubation for at least 1 to 3 months should be there. Without this, laser DCR is almost certain to fail in 2 to 3 years. Osteotomy. The size should be adequate. Less than 5, chances of failure is more. Adequate size should be 8 to 10. Site of osteotomy. Ideal site is anterior superior to the inferior attachment of middle turbinate at the level of canaliculi, common canaliculi. Some of the complications are highlighted here. Occasional bleeding, eyelid hematoma, preceptal cellulitis, false passage, lacrimal sump syndrome, canalicular stenosis, tissue necrosis. No surgical procedure is without complications, and so some of them are here also. Causes of failure, this we should remember. Scarring of soft tissue surrounding the surgical fistula, synechia of the nasal mucosa, small size of the osteotomy, canalicular occlusion. But if all things go well, be happy, no more tears. Thank you.
Thank you, sir. Thank you, sir. Next presentation is by me, and this is DCR simplified and dealing complications. Thank you. अरे नहीं बाबा, जब नेक्स्ट प्रेजेंटर फ्रंट रो में हो तो वैसे ही आदमी फास्ट हो जाता है। नहीं, ये नहीं थर्ड दिस वन, या गुड आफ्टरनून एवरीबडी. My topic for today is DCR simplified, dealing complication and challenges. Certainly no financial relationship to declare. Although intranasal endoscopic DCR is gaining clinical acceptance and popularity, the external DCR is regarded as the gold standard in terms of surgical success with a high patient satisfaction. Personal communication with many ophthalmologists revealed that failure of the procedure and tedious flap making in DCR are the main cause of reluctance from this surgery, and particularly in peripheral part of India. And as a result, DCR is ignored by many eye surgeons, and lacrimal surgery is increasingly being undertaken by ENT surgeons. And in an era when other specialties are always looking to widen their surgical spectrum, we must not lose our domain. And to overcome the problem, I started a small flap shaping technique of DCR, which is less time consuming, easy to perform, result at par, and short learning curve. And my source of inspiration was a study by Muhammad Al-Tahar from Iran. It is a retrospective and non-comparative observational case series studied by me between March 2010 to 2020, and total more than 3,000 cases I have already done by this method. Inclusion criteria is same as described by Dr. Sudhir. Methylene blue is used. देख कंप्यूटर भागा जा रहा है तुम्हारा. Methylene blue is used to irrigate lacrimal sac to delineate it during dissection, and curvilinear skin incision was made 2 to 3 mm away from the medial canthi. medial 2 to 3 mm of the sac around common canaliculi is shaped so that the lateral part of the sac remain as a disc with punctum in its middle, just like this one. Here B is the common canaliculi and A is the remaining sac, whatever sac I have shaped. 10 mm Arugaz bone trephine was used to make ostium in lacrimal bone and a passage in the nasal mucosa. And this is Arugaz bone trephine, and this one is the nasal ostium. Entire part of the lacrimal sac was sutured with subcutaneous tissue of the medial side adjacent to a newly formed ostium by non-observable 6 silk thread, medial palpebral ligament, and rest of the incision is sutured. And on a 5th post-operative day, sac syringing with 1 ml of 0.4 milligram per ml mitomycin C was done in newly formed passage near bone ostium. Complication is no unexpected complication, minor complications such as hemorrhage. Changes we made, the main part is the changes is made in this procedure is the medial part of the lacrimal sac was removed, saving 2 mm to 3 mm of sac around common canaliculi, and Arugaz bone trephine is used to make ostium in nasal bone adjacent to lacrimal sac and nasal mucosa, and mitomycin C is syringed on 5th post-operative day in newly formed passage near ostium and nasal mucosa. The patient were followed up for 1 year, and functional success was defined as the absence of tearing. Assessing the Monk's score, AP4 of grade 0-1 was considered as a success. And in some cases, I have done nasal endoscopy. This is after 1 year of follow-up. This is nasal ostium. Endoscopic view after 5 days, this is after 15 days, this is after 1 month, this is after 3 months, this is after 6 months, this is after 1 year. And ostium size shrinkage was also marked in my study, and I got the first 3 months. After that it is nearly stable and found 4 to 5 mm oval round in shape after 1 year. And the result, the total success rate, anatomical success rate is 99.27%, and functional or object subjective success rate is 98.66%. And in accordance with the endonasal DCR, which has high success rate without flap, I have obtained the idea of why not doing external DCR without flap also. So the procedure of external DCR was designed to be done with neither anterior nor posterior flap, and furthermore the technically difficult flap making in suturing, especially of the posterior flap, was overcome using this modified technique. And that's why I postulate that the osteotomy done without flap has much less incidence of adhesion and synechia that may lead to failure of the DCR in most of the cases, as described by Dr. Sudhir. What are the frequent causes of DCR failure? Okay, these are already done by Dr. Sudhir. 5.4 milligram per ml, and it was found that the safest and most effective dose of mitomycin C is somewhere between 0.2 milligram to 0.4 milligram. That's why I use here 0.4 milligram. And why on fifth post-operative day? In the present study, ranging of 0.4 milligram per ml mitomycin in the newly formed lacrimal passage on the 5th post-operative day decrease the incidence of post-operative adhesion more significantly because it is not diluted by bleeding from nasal mucosa and better coincides to early correlative phase of healing, which starts from 3rd to 5th day of tissue injury. That is the stage of fibroblast migration and proliferation in the wound. And the conclusion is the success rate of that study is 98.6%. Then the success rate among published research varies from 70 to 100%, and the sample size of studies published also range from 19 to 176, and here sample size is more than 2700. And that's why I conclude and recommend this method, because this method is easy to perform with reliable and comparative results, needs no costly instruments like laser, and can be used for mass surgery in camps because you can do it in very short time, 30 to 35 minutes, and can be used for repeat and very large DCR, dacryocystitis. Complication, no major complication, already dealt by Dr. Sudhir, that, and we are running short of time, that's why I am escaping it. I can do all these cases by this method. Thank you. I think, बॉस कुछ परमिशन है क्वेश्चन आंसर सेशन चलाने का? Any question from audience? As yet, no complication noted. Systemic complication कहाँ जाएगा? Oral में जाएगा तो कोई issue नहीं है. That is already studied by ENT surgeons. I am against use of intraoperative, because most of the time dilution by bleeding or something, and you have to wait for 5 minutes with mitomycin C. Why not just syringing on 5th post-operative day? What? Mitomycin is itself an antibiotic. That is a tedious procedure, because you can go just and
You can also give the intraoperative. Sometimes some of the people are injecting the mitomycin intrastomach, intraostium, between the mucosa and the bone. There is less chance of the actual fibrosis later. There are some scenarios coming up, maybe helpful.
because mitomycin works on fibroblast migration, on fibroblast. So you are getting fibroblast or proliferation on 3rd to 5th day. That's why I am using on 5th day. Should I say thank you everybody?